In this video, we are going to compare the two important paralyses associated with the brachial plexus injury, the ERB paralysis and the KLUMPKE'S paralysis. ERB paralysis is mainly the injury to the upper trunk, that is mainly C5 and the 6 roots are involved. And whenever there is involvement of the lower trunk of the brachial plexus involving the C8 and T1 roots, then it will causes the KLUMPKE'S paralysis. So the site of injury is different in both these paralyses. As we can see here, whenever there is an increase in the angle between the head and the shoulder, that will be the cause of the ERB paralysis. And whenever we are pulling the trunk or arm away from the trunk, it is called a KLUMPKE'S paralysis. The common examples forming or the common instances where the ERB paralysis is causing is depicted here. So in this picture we can see we are pulling the baby's head, and whenever the head is pulled away from the shoulder, it will causes the upper trunk of the brachial plexus and it will cause ERB paralysis. On reverse to that, while we are pulling the arm here, we are increasing the angle between the arm and the trunk, so it will causes to the injury to the lower trunk, it will causes the KLUMPKE'S paralysis. And there are conditions like fall on shoulder will causes this same increase in the angle between head and shoulder, it will causes ERB paralysis. So whenever we are falling on an outstretched hand, it will causes the KLUMPKE'S paralysis. Now coming to the various clinical features and the cause of these features. As already mentioned, the ERB paralysis causes the injury to the C5 and C6. We can see the two major nerves involving having the root value C5, C6 are axillary nerve and the musculocutaneous nerve. So whenever there is injury to the axillary nerve, there is paralysis of the deltoid. So deltoid is causing abduction of the arm, so the arm will be in a adducted position. Further, there will be paralysis of all these muscles. They are the lateral rotators, so the hand will be in a medial rotated position. Also, the C5, C6, C7 include the root value of the musculocutaneous nerve. It includes the paralysis of the biceps brachii. So the hand will go into a position of extension and pronation because the biceps brachii is a strong flexor and a pronator. So here we can see the hand will go into a position like this. The hand is like a adducted close to the body, and further we can see it is medially rotated. And because of the paralysis of the biceps brachii, there will be extended forearm with a pronated forearm, and this type of condition is called a policeman's tip hand. So coming to the KLUMPKE'S paralysis, the main injury is into the lower root, that is C8 and T1 is involved. So whenever there is involvement of C8 and T1, mainly the root values involved are close to the root values of this median nerve and ulnar nerve. So we can see there will be paralysis of the intrinsic muscles of the hand, that will be clawing, a clinical condition called claw hand here. It is mainly because of the unexposed action of the long flexors and extensors of fingers. And further there is involvement of the T1 fibers, so that will be causing the loss of sensation among the medial border of the forearm and hand. And more importantly, we can see there is injury to the T1 sympathetic fibers, and that will cause a syndrome called Horner syndrome. The characteristic features of the Horner syndrome include ptosis, meiosis, anhidrosis, and anophthalmos. So there is dropping of the upper eyelid called by the name ptosis, and there is constriction of the pupil called by the name meiosis. And further we can see anophthalmos and anhidrosis also present. So these are the different clinical features. We have to compare them. What is the site of injury, what is the cause of injury, what is the deformity cause, and what is the result, or what is the cause, what is the main cause of this deformity.